The next speaker is Dr. Mark Edwin. He's one of our physicians in palliative medicine, and he's going to talk today about the use of marijuana in healthcare. Across the 10 years we've been doing this symposium, this has always been one of the biggest topics that comes up in the audience Q&A, and we've actually never done a formal talk on it before, so we thought it was a high time that we go ahead and talk about this topic.
Thank you, Dr. Bryce. I have to say I'm a little relieved that I'm not going to be asked go or no go in terms of cannabis and the use of healthcare. So thank you for the invitation to present today. And I'd like to give each of you an overview of cannabis and let you come to your own conclusions of whether it's a go or no go. My goal this morning is to present some of the studies, some of the risks, and a little bit of the legislative aspects of it, and let you decide if it's high time or not. So, marijuana, what is it? A plant originating in Central Asia, a pharmaceutical agent, a street drug, a political battleground. Full credit, all of the above. Yes, exactly. So this is a topic that generates lots of interesting conversation in my office. I work in the Department of Palliative Medicine, as Dr. Bryce says, so my role is really focusing on patients' symptoms as they go through cancer care, and some of those symptoms come from the disease. Some of those symptoms come from the treatment. And it's a curious observation of mine to see patients are often reluctant to broach this question with their providers at Mayo Clinic. And one of the points that I would like to underscore is that if this is part of your toolbox, share it with your providers so that they know. Because like everything else that we're looking at, we need to be mindful of the compounds that you're taking in, whether it be the chemotherapy, the nutrition like Dr. Northfeld was talking about, or a product like cannabis. So be sure to be upfront with your providers about that. So a little bit of the background. What is it that we're talking about this morning? Marijuana is a product that comes from the cannabis plant, and typically the plant that we're talking about is this one, the Cannabis sativa plant that was originally identified in Southeast Asia. And it does have known psychomimetic properties, but also has identified itself as having medicinal properties. And that's really what we're interested in learning about. And can those properties be maximized in the terms of your cancer care? This is not a new conversation. When we look back in the medical archives, we see this conversation has been one that has gone back for millennia and has evolved slowly as other products have evolved. Cannabis is used globally. For many people, they use it recreationally. We know that about 45% of high school seniors have dabbled with it in recreational use. We know that about 20% of people use it globally for either recreational or medicinal uses. Yet it remains illegal in many countries. All of us in this room are aware that this has become endorsed or at least legalized in state legislatures, but continues to remain illegal from a federal standpoint. One of the challenges that we as medical providers have in this conversation is brought about by this, which is the Controlled Substances Act. This was legislation that was passed on a federal level back in 1970, and at that time, medications that were considered potentially harmful were classified in various schedules, rated 1 through 5. 5 was considered relatively low risk, but Scheduled 1 was considered either the highest risk for addiction and or showed no value in terms of medicinal benefit. Cannabis has been classified as a Scheduled 1 substance, and the reason that's important is that legally we cannot prescribe that. people do get certifications, but they don't get a prescription that you fill through a pharmacy. More importantly, from my standpoint, is that as a Scheduled I substance, I need to either procure a specific license in order to study it, or I'm precluded from doing so. So I'd like to show you some of the studies that are available this morning, but keep in mind these studies are very difficult to do, they're very difficult to fund, they're difficult to recruit for because of this scheduling designation by the Controlled Substances Act. So a little humor along the way. Can you prescribe marijuana to help me with the boredom of sitting in your waiting room? Hopefully that doesn't happen at Mayo Clinic. So one of the things I want to clarify too is what are we talking about when we talk about cannabis use? And I think for each of us, depending on our own backgrounds, see this as a different product. Is it a recreational drug? Is it something that has a proclivity for addiction and we need to be cautious of? Is it a medicinal tool that might come into play in our armamentarium for cancer treatments? And it's that latter one that I'd really like to talk about a little bit more detail. Cannabis is a botanical. This has historically been recognized in a number of the products that we use. So when we look at commonly used tools like morphine and aspirin, these have all evolved from botanicals that have been identified and purified and used regularly. And I think there's been a shift over the last 10 years to kind of embrace this philosophy in how we manage multiple diseases. And when we look at natural products, does anybody recognize this plant? So not every plant that we can identify is healthy. So this, of course, is tobacco. And we have recognized multiple risks associated with tobacco. So I think it's important that we do have a degree of skepticism when we look at these botanicals. Can they be beneficial? But also, like every prescription that I might provide you or any of our colleagues today, what's the potential downsides of that? Also, keeping in mind that with each of these products, they fall outside of the purview of the Food and Drug Administration. So there's no oversight in terms of purity or quality in the products that you might procure from a dispensary. So keep that in mind. As a side note, and part of one of the conversations that I have with my patients is use a healthy degree of skepticism, not just in what I say, but in products that are not screened for purity or quality. This is a study that was published by our colleagues in Canada at the University of Guelph that looked at products that were identified as botanicals. And they used DNA analysis to see, does the product that is taken off the shelf contain what is advertised on the label? And if so, is it pure? This was done with 44 products that were purchased both in the US and Canada. And it's a little disturbing for me that 34% of the products contained none of the advertised ingredient that was on the label. And about half of them contained contaminants, which may not seem like a concern except for those who have significant allergies, such as nut or fish or perhaps a gluten intolerance. So my point with sharing this with you is just use a degree of skepticism when you're purchasing these products, or if you go to a dispensary and are getting information from one of the providers there. So let's talk a little bit more about the plant and what it is that will be discussed if you choose to use this tool and visit a dispensary. In the marijuana plant, there are about 400 compounds, 100 of which are identified as cannabinoids. The two products that are mentioned most frequently are the two that you see here, THC and CBD. These are the products that are most prevalent in the plant, and they're the compounds that are most biologically active in the plant. THC has a propensity for more of the psychomimetic, the high, if you will. CBD tends to have more qualities in terms of a pain reliever and also an anti-inflammatory. When patients go into a dispensary and are looking at different products, oftentimes they're given information about the ratio of THC to CBD, or are looking for products that may be exclusively one of those two products. I think that's reasonable, but keep in mind, purifying out the 400 other compounds is a challenge. So you're probably getting some component of each. Well, how does the cannabis products affect our body? Most of the time, patients are now using these as oral preparations. So there's a variety of edibles that people can purchase. They can be taken in as gummy bears, as teas, as tinctures or oils. And like most medications that I prescribe, it takes about 45 minutes to an hour for that to be absorbed and have a physiologic effect. And that effect may last for 3 to 4 hours. It's not much of a departure from other things that we utilize. For patients who choose to inhale the product, it can be taken in two ways. It can be either smoked, where the plant is burned, or it can be vaporized. So what is vaporization? Vaporization is where the plant is heated, but not burned, heated to the point that the products become aerosolized or become volatile and can be inhaled. When you inhale the product, the effect is much faster. It's absorbed directly into the bloodstream. The clinical effect is within about 10 minutes. Oftentimes we caution people who may have a history of lung disease in avoiding definitely smoking because you're getting particulates from that. So patients who have emphysema or COPD or a variety of other lung diseases, we do caution against using the product that way. Cannabis is a fat-based compound, so that characteristic allows it to be absorbed through the skin. That's difficult to measure, but for patients who use creams or topicals, it will absorb through the skin over a period of hours. So the one dog says, "Is that grass?" "Yeah, but I take it for medicinal purposes only." So I'd like to show you just a sampling of studies, and the way I have divided this is based on symptoms. And as I present these studies, you'll find a theme in these, and the theme is this, that the studies are very small, and they're often difficult to kind of think, gosh, does that apply to me or not? Because they're done in groups that are close to cancer, but not directly done consistently in cancer patients. So there's a little bit of seeing if we can get that round peg in the square hole. So let's go through these. And I wanted to start out with pain. This is the question that I get asked most oftenly. And when we look at cannabis products, this is an old study that was done in 1970. I'm going to make no reference to Terry Taylor, but so this was a study that was done looking at volunteers who were using pain medications and trying to equate, does cannabis compare to opioids in terms of pain relievers? And what this author concluded is that in single doses, 10 milligrams of THC is equivalent to about 60 milligrams of codeine, or 20 milligrams of THC is about the equivalent to 120 milligrams of codeine. Now, how do you put that into context? On average, if you were to smoke this, if you were to take a joint, a marijuana cigarette, that contains about 8 to 10 milligrams of THC. If we were to convert it to morphine, which is kind of our prototype of opioid pain relievers, it'd be about 8 milligrams of morphine. So what does that mean? The starting dose of morphine, if I were to prescribe it, comes as a 15 milligram tablet. So this would be at about half a tablet of the lowest dose of morphine, just to kind of give you a frame of reference. This is where we may depart a little bit from oncology care, and that's because many of these studies come from the University of California in San Francisco. Dr. Abrams up there is an integrative oncologist and has that specific license that you need to do Scheduled I studies. And he looked at a population of patients who had nerve pain specifically related to HIV. Nerve pain is probably the most challenging pain to control. It's much harder to control than, say, cancer that might be pressing on another organ or a broken bone. When you have damage to nerves, it tends to be refractory to medication. So it seems like a reasonable population to study. So what Dr. Abrams did was bring in patients who had previously used cannabis for recreational purposes and put them in a controlled environment and allowed them to use cannabis over a period of 5 days and quantified their pain. In the medical world, if we see pain go down by 30%, that's a thumbs up, that's a go. If we can get your pain controlled by 30%, then we're making some headway. And what he found is patients who used cannabis had a significant improvement in their nerve-related pain, which then went back to normal when they stopped it. This didn't seem to correlate with dose, so he used 2 different doses, 19 milligrams and 34 milligrams versus placebo. Curiously, each of those groups showed some pain reduction. The 2 cannabis doses were more effective, but neither dose seemed to be more potent than the other. So it didn't seem to be directly related to dosage. I put this up just as an incidence or a frequency that we see side effects. And the reason why I point this out is because as I look at each of the studies, regardless of why it's used, pain, nausea, appetite, this side effect profile seems to be repeated, which is curious because when you look at the incidence, some patients seem to have a higher risk of nausea or a higher risk of anxiety, which is often why patients choose to use it. And there appears to be a subset of the population that develops these specific side effects. We don't know why, but it's a pattern that's pretty consistent across the variety of studies. A question that I get asked often is, gosh, doc, I'm taking this morphine or I'm taking this fentanyl, my pain is still not great, I can't do the things that I want. The scenario that I find happens a lot, I'm not sure why, but it's usually my kids or my grandkids say I should try pot. What do you think? I'm not sure, nobody seems to take full ownership of, I'm thinking of trying it. It's usually somebody, my wife. So anyway, okay, tell me what your grandson said. But the question then comes up, can I use cannabis along with my opioid? Insert whatever product you're taking. So the group in California looked at this question, can we combine cannabis with opioids? And if so, is it helpful? Is it conflicting? What do we see? And so what they looked at was the vaporized cannabis. And this is one of the vaporization machines called a Volcano. So this is the product that they used in this study. And what they found was that in patients who were using opioids, the addition of cannabis was synergistic, meaning that 1 + 1 didn't give us 2, 1 + 1 gave us 3. There wasn't a change in the levels of opioids, so it wasn't that it drove the morphine levels higher. It seemed to be that by going through 2 different pathways to control pain, there was an additive benefit without increased risk of side effects. So that's reassuring to me. These are very small studies, but it doesn't raise any red flags. That's good. Well, what about nausea? This is probably the indication that most people will tell me, my grandson told me I should ask you about using cannabis. So, from the senior citizens, really feeling my joints today. Me too, as she holds a. So oftentimes when people will reference cannabis studies and pot studies, the one thing that I would caution you about as you Google these or look on the internet, most of the studies that were comparing cannabis to see if it helps with cancer or chemo-related nausea showed benefit. But the caution is this: what they compared it to was either placebo, in other words, nothing, and of course cannabis was better, or they compared it to the agents that we used a generation ago, the agents that we know were not particularly effective for chemotherapy-induced nausea. So a lot of those studies are comparing apples and oranges, so I would caution you against that. The products that we use now have been compared in only one study, and that's in this bar graph that I show you here, which does cannabis help with nausea? Does Zofran, which some of you may be familiar with on Dancitron, control nausea? Is it better to use them in combination or placebo? And what you can see here from this graph is that the cannabis, the Zofran, and the combination of the two were relatively equivalent across the board. They were better than using nothing, but none was sort of our out front go, in Dr. Northfeld terms. None of them seemed to be an outstanding choice. So if people choose to use that, that's not unreasonable. It doesn't appear to be helpful if you're using other products that may have been prescribed by your doctor. It's about the same. So it's essentially a wash from when we compare it to the current nausea medications that the oncology team is using. Unfortunately, that's the only clinical study that we have looking at nausea and cannabis. The third area that I see patients ask about is with appetite. And again, Junior's coming in telling you he ate a whole bag of Doritos after he was smoking pot last night, and you got to try this for your weight loss. Does that really carry out? One of the things that I would really import to you is that when you compare someone with cancer versus somebody who is going to university, and they may both be using cannabis, the process that's going on inside the body of that cancer patient is much different than a healthy person. Many of you in the room already know that. The impact of cannabis seems to be blunted in terms of regenerating appetite and regenerating intake of food. So when we look at that, if we try and study that, this is a study that looked at around 250 patients that had a variety of cancers, lung, GI, hematologic malignancies, and they were given three options. They were given the option of taking THC and CBD, taking THC alone, or they were given placebo, nothing at all. And then we measured, did their appetite improve, and did it improve their quality of life? And what we found is that the impact of each of those products was almost the same when measured in cancer patients. I can tell you in my population, when patients come in and have been using cannabis, the feedback that I hear, this is very anecdotal, the feedback that I hear is that it may help with pain, it might help with nausea. I can measure on one hand the number of patients who've told me it really helped them with their appetite and increase in food. So it's disappointing, particularly when patients have lost 30 or 40 pounds. Their family becomes increasingly concerned because clothes are loose, people start to look ill. Family members or neighbors may start to ask, how are you feeling? And they're hoping to regenerate some of that appetite, and it really has not matured to the point that we see that result. So take-home points with regards to that is we see minimal effect with appetite and minimal effect on weight gain. So let me shift just a little bit to some of the pragmatic aspects of using this product. So in Arizona, This law passed several years ago by just a hair of a margin. 50.13% of the population voted to approve the use of cannabis as a medical product. We were the 15th state to do so, and it was implemented back in 2011. In this state, you can qualify to get a medical marijuana card with any of the diagnoses you see listed there: cancer, glaucoma, HIV, ALS or Lou Gehrig's disease, Hep C, Crohn's, and the rest that you can see. Most patients will qualify under the context of having a chronic symptom, typically pain. When you look at the state registry, by far and away, the vast majority of people procure a card based on having chronic pain. So for patients who choose to pursue this, they do have to go through the process, which is done almost exclusively online. All the forms are filled out online. Patients are asked to sign a consent saying that they will not divert the cannabis to anyone else in their family or friends. They're allotted up to 2.5 ounces every 2 weeks, unless you live greater than 25 miles from a dispensary. If that's the case, then patients are allowed to grow their own plant. And Arizona will recognize other states' cards. So for patients who travel from California or another state that does have medical marijuana certifications, Arizona does recognize those. This does have to be renewed annually. I don't remember the cost. It used to be about $150, but that may have gone up. Like any compound that is taken in, there are side effects. We touched on that a little bit, and you see those here in terms of dizziness, confusion, the curious side effect of nausea and anxiety, some memory impairment, and difficulty with concentration. Patients are cautioned against driving just as they would with any other compound that may affect reaction speed. And for people who are looking at this literature, there is some evidence that shows that there appears to be a higher risk of coronary events, heart events. So for patients who've had a history of heart disease or have had a recent heart attack, that's something to be mindful of. There's not a lot of clear cause and effect association, but something to be mindful if that's applicable to you. Many people will think of cannabis, and for those who have teenagers, as I do, that worry about, is this a gateway drug? Is there risk of addiction becomes the forefront of their minds. When we look at the risk of dependence, it is there. When you look at the studies from the federal government, the National Institute Against Drug Abuse, and compare the incidence of addiction, you'll see those listed there. So the incidence of addiction to nicotine is around 32%, heroin 23, cocaine 17, alcohol 15, and marijuana is 9. So curiously, that is the lowest of the compounds that we often associate with other agents, particularly with all the information that's in the news regarding opioids. So kind of keep that in mind. And this is that same data, just in a different format. So take-home points that I would like to leave with you today. I will leave the thumbs up or thumbs down to each of you to think, is this something that I want to have in my toolbox? Is it something that can complement what I'm using already? Just a note of caution that there is very limited oversight of that industry. And the other caution that I would leave you with is that there is very little data looking at, for patients who use cannabis, particularly regularly, how does it affect the blood levels of other compounds that you may be taking, whether that be blood pressure medications, diabetes medications, or chemotherapies. Does it raise that level? Does it lower that level? So always go in with a degree of caution, because you can ask your physician, is it safe? And he or she does not have the data to answer that question. So it is a let the buyer beware, because we can't offer you great guidance on that. But when we look at the data, there does seem to be a role in terms of pain control, in terms of nausea control, but very little support that it may help with weight gain or appetite. So for those of you who are research nerds like me, here's some data that you can look at, and I will be happy to be around later if you have any specific questions. Thanks so much.